Okay, and good morning, and welcome to the Davies Use Case webinar being presented by Banner Health on urgent care. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support, best practice guidance, access to clinical data to analyze progress, information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's call, Dr. Rob Rohash, Dr. Cosmela Runkle, and Dr. William Holland. I will turn the presentation over to you all, and you can begin when you're ready.
Good morning. My name is Rob Rohash. I'm the CEO for Banner Urgent Care and Occupational Health Services, and I'll kick us off here. Banner is a large integrated multi-state healthcare system consisting of 28 hospitals that are a combination of acute and rural hospitals across the 6 states. They employ many of their own physicians through Banner Medical Group and have just around 2,000 providers employed under that group. There's a large university division based out of the University of Arizona in Tucson with assets also up in Phoenix. Banner has recently invested in a large, robust ambulatory division consisting of urgent care centers, ambulatory surgical centers, imaging centers, and a telehealth platform, and is right around an $8 billion system today. Our mission focuses around Sophia, who's our avatar who represents all the patients that we see in our health system. And whenever there are questions around care delivery and quality, we revert back to the question, what's the right thing for Sophia? So we do that by focusing on helping our patients be their healthiest, reaching our tentacles out into the neighborhoods where our patients live, work, and play, and growing our impact. We believe in our employees being the key to all that. So one of our strategic goals each year is to engage and inspire our employees. And at the end of the day, we want loyal, dedicated patients that want to come to Banner for their health care. So perfecting and measuring that experience against industry standards is part of how we do that. So the local problem we wanted to address is how does a large health system fully integrate an ambulatory platform like an urgent care platform into its overall health care system with the goal of driving accessibility and then increase coordination of care delivery. So the goal in this case wasn't just to stand up an urgent care platform through a M&A transaction. It was really how do we fully integrate this system, this platform where system assets receive a lift due to what we're doing. So kind of a case of 1 + 1 is 3 is what we're looking for. In my background previously, I was consulting in this space and found that most healthcare systems view urgent care platforms as another service line to compete against other urgent care platforms. And the reality is when fully integrated, the power of these platforms to help solve population health and growth and access strategies is actually quite enormous. So Banner made the announcement to go into the urgent care business and closed in November of 2016 and created quite a bit of buzz in the community, ranging from journals that wanted to reach out to us for interviews that specialized in healthcare contracting, to legal entities, to supply chain management, but everyone wanted to know kind of what we were doing entering into the urgent care space in that sort of healthy manner in which we did with purchasing a large platform. And the bottom line was it was an aim at the at hitting the triple aim, so controlling cost, really delivering the wow factor in the patient experience, and at the same time delivering high quality health care. So this was a consumerism play, and we'll talk today about how we leveraged information technology to accomplish quite a bit of integration within a large health system in a short amount of time, and most importantly with measurable before and after results. So we kind of threw down when we were talking to these journalists and really made some bold statements around wanting to really sort of have a strong consumerism play and own the populations that we serve in the 6 states where Banner has assets. We literally wanted the construction worker that was falling, one story off the scaffolding to mumble to himself on the way down that I'm going to Banner today. So we really want to own that sort of patient experience, and it was determined that being in the urgent care business was part of that strategy. So in a nutshell, this in one slide, this is why Banner bought the urgent care platform. It was an access strategy playing into a market share strategy, which then played into a population health strategy. So from an access perspective, the urgent care platform provided an easy mechanism to increase access to primary care physicians within Banner via direct referrals to prevent leakage to competitors by making sure that we always offered same-day access over 90 hours a week to our existing patients. It provided increased access to emergency departments via direct referrals, to specialists via direct referrals, and we've recently launched a program that's working very well that provides access to open schedule slots in our medical group so we can directly make appointments for our patients before they leave the urgent care center and capture new patients into the healthcare system via that mechanism. Next, it was a market share strategy, and this is basically increasing the footprint so we can be available and in front of consumers in places where they live, work, and play. This was a cost containment strategy as well. About 20 cents on the dollar is what it costs us to take care of minor injuries and illnesses that otherwise would end up in the emergency department. This was a brand awareness strategy, so it was important to Banner to have their brand more widely spread in the communities that we serve. And finally, this led to a population health strategy, and I won't bore you with reading what's on that slide, but I will sum up one piece of this population health play, and that's interestingly what we feel is going to be a risk shift, meaning that by definition a lot of folks that come to urgent care centers when you control for their age and other comorbids are probably more healthy than their counterparts by definition, in that they've chosen not to have a primary care, don't have chronic disease management issues, and only come in when they're kind of sick or hurt with minor illnesses and injuries. So if we can plug those folks into our system, have them become members of our medical group, we can sort of change the risk shift, so to speak, that a large integrated healthcare system is always looking for. So the old delivery model was basically this pyramid flipped the opposite way that you see it now, with hospitals being on top and a very hospital-centric delivery model. And as we all know, this is a customer-first centric delivery model now, with consumerism being sort of the top of the funnel. before the concept of on-demand medicine, which is defined kind of by urgent care, retail, same-day access to primary care, real-time appointments, text messaging. Before those became much as popular as they are today, this pyramid existed the way you see it, but without the on-demand care on top, and a truncated entry point into primary care with poor access given the shortage of primary care providers in our country today. So what on-demand medicine does, what urgent care does, is it increases the relative diameter of the catchment funnel within a system. So it's kind of flipping the old model on its head and focusing on capturing folks into the healthcare system for a wellness and health strategy. So this slide basically shows you the same thing. It's a volume to value-based care play with population health being centric and focusing on the consumer at all inflection points in the process. So this is a map showing that as of November of 2016, Banner went from essentially no urgent care centers in its platform to 32 centers overnight. And it was a large undertaking in January of 2017. Current Banner employee management took over, the platform and immediately started the process of design and implementation in the planning process around that. A quick note on the payer mix. You can see we are challenged with approximately 42% of our payer mix being government-sponsored insurance, and that's okay, because we want to make sure that folks are seen in the right care setting, at the right price, by the right providers for their given illness and injury, and that applies across the board, and that's good for the system to make efforts in that direction. So I'd like to introduce you to Dr. Dana Kosmala. She'll take over from here, but I do want to briefly introduce this next slide before I turn it over to Dana and talk to you about my third day at work. I'm not at full liberty to discuss everything that happened in this room, but needless to say, there was what I would call a spirited conversation with clinical informatics, information technology, and the operators in the ambulatory division around what type of EHR needed to be embedded into the urgent care platform to meet the needs of the system, and also to meet the needs of the patient and the urgent care providers as well. So it was a long 2-hour meeting. It was really a conversation around a boutique best-in-breed EMR that solved the value proposition for the patient in urgent care medicine, which was efficiency and respect for time and in and out very quickly, and how do you balance that against the benefits of full integration into a large healthcare system. And I can tell you that I was leaning towards the former versus the latter given my experience. I just was sure it was not possible to build an EMR platform for urgent care medicine that allowed the value proposition to shine through and would meet the needs of the patient. And I'm happy to say at this time that I was very, very wrong about that. So at this point, I'd like to turn you over to Dana to walk you through the design and implementation process.
Thanks, Rob. Hi, all. I'm Dana Kosmala. I'm a physician senior director on the medical informatics team, and I'm going to walk through how we walked through this process going from acquiring an urgent care system to implementing an EHR, and how we were able to follow that up with some of our metrics. So again, even though in the earlier slide you saw we had the spirited discussion around the table, even though that table was round, there were definitely clear sides about how we were going to move forward with this. And those discussions were centered around efficiency and integration. We had a best-of-breed system that was the efficiency side of the argument. These were created specifically for the urgent care. It was available out of the box. There wasn't a lot of design. There wasn't a lot of build to it. That it was take it out of the box, put it in the urgent cares, and hit the ground running. With the integrated side, we also had a large integrated EHR platform, and part of our urgent care strategy was to use these urgent cares as part of our bigger health system, not just to use them as a service line and get people in and out. So we had the side of integration, which was we could have this longitudinal record, make the urgent cares a piece of the puzzle, and we already owned this, so there wasn't a big cost associated with it. The downsides of doing that are urgent care is a fairly new service line, and implementing it into this bigger model was a fairly new concept. So we would have a lot of design and build that we would have to do on our end to make this work. And we were on quite a short timeline because we had about 4 months to do this work. So there was a lot of concerns coming from the efficiency side that the integration side might not work. But regardless, we had to do something. Currently, all of these urgent cares that we had acquired were all using paper from start to finish. There was a paper registration that was a form that patients filled out on arrival. There was a paper chart that vitals were recorded on and intake was done. The physicians or physician assistants did their documentation on paper, and then when the patients left, they were given a paper handout with their discharge instructions and the specifics of their visit. So obviously part of the problem with this was in an integrated health system, when everything's on paper, there wasn't any integration. Even going from urgent care to urgent care, they didn't know if that patient had been seen previously in their system. They didn't have access to whether or not the patient had been seen at a primary care physician, had been seen in the hospital, and they had no way to, if they had to send the patient somewhere, they didn't really have a good way to get that information to the receiving provider. So as much as we could have the efficiency versus integration discussion, there was a point we had to make the decision. So coming back to that, we kept just going back and forth with the efficiency integration, but then after a couple hours in there, we started thinking that maybe it doesn't have to be either or. Could we do both? And what we wanted to do was use our longitudinal record to meet these industry standards of the best of breed systems and keep the total length of stay in our urgent cares under 60 minutes and keep the provider documentation to less than 2 minutes. And of course, because these were designed to be urgent care, we wanted to keep the process simple. So the first step that we did was, could we do this with our current system? And what we did is we looked at some of the data that others were using. There were other clients who were using the same system we were using, and they were using it in urgent care settings. Maybe not as big or as many, but still in that same venue of care. So this is one example where we looked at the time spent documenting. This was important from the operational leaders. This was important to our clinical end users. This is something we wanted to make sure that we could definitely meet and keep that documentation time under 2 minutes. So we looked at all of the clients who were using urgent care and what type of documentation they were using, because that was another choice we had to make. Do we use the Cerner's PowerNote version, or do we use their dynamic documentation solution, which are two very different documentation solutions? So we looked and determined that, yes, there are clients, there are many, who can keep that documentation time close to or under 2 minutes, and that we could use that dynamic documentation solution to meet that need. We also then had to look at some of the other requirements and some of the other design decisions that we had to make. We had to look at a registration system. We had 2 models in our current system and needed to look at which one would work better, because it didn't make much sense that if we kept the documentation time under 2 minutes, but we had a registration solution that took 45 minutes, that's still not going to give us the end result that we need. So going through this list, these were just, again, looking at the clients that were using the Cerner solution in their urgent cares, what were they using, how successful were they, what kind of metrics were they meeting, and how could we get this urgent care model designed and in place to where we would meet these operational needs. So could we build this urgent care model? At the time with urgent care, again, being such a new venue, a new service line, there weren't a lot of overall vendor recommendations. We had examples from what people were using, but there wasn't one overall overwhelming recommendation that we could plug and play. So we had to develop that ourselves. Again, we had about 4 months to do this, so there was definitely, time was not on our side for this one. So what we did is we used some of our engineering principles. We talked to our engineers and we talked to our Cerner colleagues, we talked to the operational leaders and end users, and we looked at all of this data from all of these other sites and built a foundation urgent care model. So with that, we built some of the foundational workflows. We built the foundational positions. We built that basic registration system that, based on the data, would work best. And then once we had that foundation built, we could take that to our operational and clinical teams to tease down and get those final detailed decisions. What we didn't want to do is take this blank slate to this large team and say, what do you guys think? Give us some ideas, because we would have never accomplished what we accomplished in 4 months if we would have taken that approach. So using this foundational model worked quite well, that we had that foundation in place, and then they could tease out some of the issues, they could give us those detailed solutions, and we were able to work together to move this forward. So again, with some of our workflows, we have an ambulatory arena that's using our Cerner solution, and we had some of the previous Cerner clients also had some of these workflows established. So we took those and were able to tease and tweak those to make sure that we had a workable provider workflow. We looked at registration and again looked at all the parts and pieces start to finish to make sure we had these workflows established. One was to show that we could do this in the Cerner platform. The other was because, as mentioned, Rob said we went live, or we acquired 32 of these. In between the acquisition and the time we implemented Cerner, that number had grown to over 40 and is continuously growing. So we wanted to make sure that we had something established that not only would work with the current model, but would also be used in future implementations and future rollouts and future growth, that this could be used in those settings, could be used as a reference for our support teams, could be used as a reference for really anybody who needed to come back and reference this. So again, we looked at provider, this is one example of our provider visit, start to finish, and I know it's a little tough to read. And we looked at, from the MA nurse, the time that intake happened to the time the patient was discharged. And again, we wanted to have this standardized process in place so it would work in all of the urgent care settings now and moving forward. So when I say we had to take this to the operational teams and get these decisions, for our initial governance strategy, this was basically we locked people in a room again. The roundtable session worked so well that we locked people in a room again and said, hey, here's what we have so far, here's the end state that we need to get to, these are the decisions that we need made, and we have to do it today, nobody gets to leave until these are done. And it worked. We had people, again, around the table, we had great discussions, we had the operational leads, we had informatics, we had IT, we had our Cerner team, we had everybody on the same page agreeing to how we were going to move forward. And this involved everything from workflow to registration to what clinical content was going into Cerner, what orders, how were we going to work with radiology and interface x-rays and x-ray reporting. And we were able to, again, in a short time, get these questions answered and get this developed. What that evolved into is our clinical consensus group for urgent care. So this is our newest clinical consensus group, and this is a more formal process of what we did by having everybody in the same room making those decisions. What we do now is we have this group that we can take some of these questions to, we can take some of these foundations to, we can review some of the data from previous to see if any changes are going to be made, and we have all of the right people available around the table that can help us with that continuous improvement and can help us make these decisions and continue moving forward, continue expanding, continue improving, and continue growth. So this is where we're looking at what we use our clinical consensus group for. We have our define, design, and implement process that we just continue in that cycle. So we look at what's going on, or we identify if there's any problems. Then we design that solution with our informatics, with operations, with engineers, with whomever we need at the table. And then we implement it and monitor it and then go back to see, is there continued changes we need to make, or was that successful, and are there any other problems identified that then we need to work through this process. So this is our sustainable governance model that we can continue to keep our urgent cares functional and keep them continuously improving. So I've mentioned our 4-month timeline a couple times now. This was what we did in a summary on one slide. So as Rob mentioned, we acquired the urgent cares in November, but they didn't really become ours that we were able to go in and investigate and talk to the employees until that January 1st date. Then we were, after that, we had to get, because of everything being on paper, we had to get a registration system in place pretty quickly, that we had to make sure that we could track what patients were being seen and how they were being seen in different areas, or if they were going to different places. So we implemented our registration system in February, and then the official big bang was in April of 2017. And on here, you can say we did 39 facilities. We had initially acquired 32. That grew to over 40, but because of construction issues and other limitations, there were 39 of them that went live on that Big Bang Go Live day. So how did we do that? We had 39 all going live from paper onto an EHR system, all on the same morning. So what we did is we established a new urgent care specific command center. And what this was for was a call-in that anybody from any of these sites could call in and talk to the experts who had designed the system, who had established these workflows, and who could help with some of the issue resolution and could also track some of the enhancement requests with how we could make this better. And we were already starting the improvement model as we were going live. Also, we had on the first couple of days, day 1 and 2, we had a Banner or Cerner support team member at the elbow at each site. So we recruited all of our support team, we recruited people from Cerner to help us with this, knowing this was a big endeavor, and had them on site at every single site. So this command center, either the support team could call in or the end users themselves could call in, and we were available. Because we had this just massive support at the start, by the 3rd day, we were able to already cut back and have one person for every 2 sites. So instead of having one person at every site at the elbow, we had one person going back and forth between 2 sites that were there to help troubleshoot and help, and then we were on, that was for day 3 and 4, and then on day 5, that at the elbow support was no longer needed, and we didn't need the specialized command center, that we were able to transition this back to our normal troubleshooting and our normal service desk calls reporting issues on day 5. So post go live, we started looking at, did we truly integrate this? And one of the benefits of putting the urgent cares on our integrated system was that we could use the urgent cares potentially as a patient intake. that they could see the patients and get them into our system as far as, establishing with primary care or getting them to a specialist, or if they needed to be admitted, that they were already capturing all of this patient information and the patient could transition much more easily to other venues of care. What we didn't realize is how many patients that were seen in the urgent care had already seen somebody at a Banner facility or clinic. So when these urgent care clinics went live, many patients that they were seeing already had a medication history entered. They already had their procedures documented. They already had radiology results and lab results that were in the system that they didn't have to track down. They realized that this was an increase for their efficiency as well. It wasn't just them helping the rest of the system, that even on day one, they were able to see the benefits of being part of this integrated system. So again, what were some of the keys that we were able to do this on such a rapid timeline and create this new model for urgent care is we had stakeholder engagement. We had everybody from CEOs, CMOs, clinical leaders. We had everybody in our Banner leadership. Everybody was committed to making this a success. And so when we had or needed these all-day meetings, people were engaged and people showed up and were there until those decisions were made. We also had people committing to this timeline. This was a short timeline and a lot of work to do, and it took a lot of resources. Everybody was willing to dedicate those resources to ensuring this was a success. Having this process standardization in place already using our clinical consensus group model is we were able to then mimic that for urgent care and develop that urgent care CCG to where we could have the standardized process. And again, going full forward with the support early on was huge to the success, and to be able to get everybody from paper using the computer comfortably, that it was an investment that easily paid for itself. So I am going now to transition it back to Rob and see, he'll tell us if we actually were able to meet some of those industry standards and some of those metrics.
Thanks, Dana. A widget manufacturing company that produces widgets off an assembly line has a definition of what a successful product looks like, and they hold themselves accountable to create that product and they measure that product. So this is my favorite part of this talk, because we get to talk about how the rubber meets the road, and we get to talk about what the product is urgent care is trying to deliver. And compared to other parts of medicine and other parts of our healthcare system nationally, this is relatively simple to describe. It's an equal combination of high clinical quality mixed with consumer loyalty. The high clinical quality piece is sort of table stakes, and it's checked off being part of a large integrated health system that spent years and years focusing on clinical quality and variability reduction, and being part of a clinical consensus group where we have access to experts in every different field in medicine. Having a chief medical officer completely dedicated to clinical quality sort of checks that off. But the consumer loyalty part and how we're meeting the value proposition is tough in this business. And so let's look and see how this kind of all shook out in the laundry here. So one of the goals, as Dr. Kosmala mentioned earlier, was to keep average length of stay under 60 minutes for all our patients, and keep provider documentation time less than 2 minutes. And you can see each thin vertical line represents one of our 175 providers in urgent care, and you can see that the vast majority are under the 60-minute target line, with a few outliers that we put into a 3-phase program to provide the clinical tools in their armamentarium to be able to become more efficient. So at the end of the day, we've been able to show that this platform, and working with our IT and clinical informatics colleagues, has made us more efficient. But so what? Because right after this happened, we entered into the busiest flu season that we've seen in this country in many years. And I'll throw just a few data points out there that match up to this slide. but the flu outbreak caused a 97% increase in volumes. So doubling our volume, that required us to increase our staffing model by only 7%, given the IT infrastructure in place that allowed us to remain efficient. Our length of stay continued to decline despite this rapid increase in our volumes. So all three metrics lined up perfectly, and we started to see the dividends and the fruits of our efforts through this integration work in real time in one of the busiest flu seasons in the country, in one of the largest healthcare systems in the country that owns one of the largest urgent care platforms in the country that at the time was in its infancy. So quite an impressive feat by my IT and informatic colleagues. We were looking for a 20% reduction in documentation time in the chart, and that only shook out to be a few minutes in reduction, and we can talk a little bit about what that means. Part of it relates to the patient value proposition of being efficient, but let's look at just what a few minutes of documentation time per provider, per patient, per day, per clinic looks like from a dollar perspective. It was around a $4.5 million cost savings to get under 2 minutes, which you can see we accomplished for the first time in September of 17, but have been holding steady as of late this winter. But it also provides two other important things that are worth commenting. One, our provider engagement has increased, and that's because we're asking them to spend 2 hours per day less documenting time, and that's per provider. That also indirectly increases patient satisfaction because that provider can now see more patients more efficiently and continue to have respect for our patients' time. Our providers work 13.5-hour clinical shifts, so you can imagine changing that to a 15.5-hour day with the increased documentation time would be rather untenable for our staff. So sort of the next layer on top of how we're going to use information technology to be more efficient and provide a robust consumer-facing strategy was our digital platform. So you can see here kind of what it looks like when you're with your smartphone near one of our urgent care centers. The device will sense the closest Banner urgent care centers to where you're standing and provide you estimated wait times. It gives you the ability to hold your place in line at an individual clinic, and once you select your clinic, it will offer you up a button to request a ride via Lyft or Uber. It'll also allow you to look at the bus schedule to the nearest bus stop closest to where your device is, and also allow you to hail a taxi cab should you want to do that. And this is basically a queue management software. It's white labeled for Banner, and there's several companies that offer these services. And from my perspective in the on-demand consumer space in healthcare, I think it's table stakes to be able to sort of reach out and touch consumers early on in their journey. This is the software we use. It's called Clockwise, and the important part about this is this is the percentage of folks registering to be seen online, and 20% is kind of a consumer best-in-class ratio. So 1 in 5 folks are reaching out to us and registering online, which helps with efficiency. It helps with demand management strategies. It helps us understand what's going on in local emergency departments and how we can decant some of those folks as well. So we sort of reached our goal at 20% right around spring of 2018. And so this is really where the rubber meets the road. This is kind of how we stack up, and what we want to show is if our value proposition is efficiency coupled with a world-class experience for our patients, how do our Net Promoter Scores stack up? And if you recall, a Net Promoter Score is basically the answer a consumer gives to the question, how likely are you to recommend Banner Urgent Care to your friends, families, and colleagues? and 9s and 10s on a 0 to a 10-point scale register, and then 0 to 6s are considered detractors, and anything in the middle is considered neutral in how we calculate this. So we're at right around 73 from a Net Promoter Score perspective, and we can see here in this slide that correlates indirectly with the length of stay. So we know that length of stay is a driver of Net Promoter Scores, and we also, through our work with process engineering, have been able to assign a relative weight to that, along with other variables that we can ask on our survey that drive Net Promoter Scores. We're sharing this information, by the way, with the system because we think it's applicable across other service lines as well. So what does that mean? A Net Promoter Score of 73. Well, you can see here that some of the world-class leaders in areas like online shopping, auto insurance, and hotels have average Net Promoter Scores ranging from close to 0 and as high as in the 50s, with world-class leaders within those service lines having scores as high as the sort of mid, even upper 70s. So Banner Urgent Care Service, as it relates to how it compares to other healthcare service providers, is in the same class as Amazon, USAA, and Ritz-Carlton from a hotel perspective. So sort of world-class service. And we know the behaviors of folks that give us high Net Promoter Score rankings in terms of what they're willing to do to drive past competition and remain loyal to Banner Urgent Care and to Banner as a system. If waiting rooms look disturbing to patients when they walk in and they know there's going to be a long wait, we often suffer what are called left without treatment folks, and these are folks that come in and decide that for whatever reason they don't want to wait to be seen, but they have registered. And so we've looked at those numbers, and we don't like those numbers for a variety of reasons. One, it's bad for Sophia at the end of the day, bad for our consumers, and it has an economic impact as well. And the bottom line is patients aren't getting what they came in to get. So we've cut that almost in half, our left without being seen ratio, despite a doubling in our volume. And we've done that through the efficiencies provided through an integrated EMR, where 7 out of 10 patients or more now, I think, don't need to go through a registration process at Banner Urgent Care because they've seen or been involved with the Banner system at some point and have already been placed into the Cerner system, which allows us an expedited way to register them, usually lasting less than one minute from a registration process perspective. So we do send folks to the emergency department at times if they've mistriaged themselves and shown up at an urgent care center and they need a higher level of care, and we track what that rate of referrals are, because we want to make sure that if we send a patient to the ED, they fall in one of 4 or 5 buckets, and those are they need a higher level of care as it relates to multi-slice imaging studies. They need to be admitted to the hospital. They need to be observed for a 24 or 48-hour period of time. They need to see a subspecialist to rule out a life or limb-threatening illness, or the last category would be what I would call a high-degree tune-up. An example of that would be a young pregnant mother with intractable vomiting that would need 4 or 5 hours of work to get her feeling better, and we may not be able to provide that level of resources to that patient. But by and large, everybody else needs to be seen, treated, and discharged from an urgent care center, and that's in keeping with our value proposition. The consumer journey, we know from field market research, in a patient's eyes, when you first start talking to them, really exist in the doctor-patient relationship and what happens in the room in the clinic. But when you dig deeper and ask consumers more questions about where their frustrations arise from, and quite frankly where their delight stems from, it's often the high-touch environment we can create before and after the visit is over. So how we market and face our consumers in the digital world is extremely important to attract them to our clinics. But then what happens afterwards? And what we're showing you here is a text message that all our patients receive within a couple days of being seen, and they're offered the opportunity to settle their bill if there's an outstanding patient responsibility related to their balance. The mobile device will show them a picture of the clinic they were seen at, show them the name of the provider that they saw, and if those are correct and match the patient's name and birth date, it takes them to their bill, where with one touch they can make their payment. And so what that does to your accounts receivable is it drastically reduces that. And actually, I believe the number is 48% of our folks that were offered this up paid the first day that they got the text through the patient portal through our revenue cycle vendor. So we believe this is a high patient experience. In fact, 37% of our complaints stem from activity that occurs after the provider has seen the patient and signed the note. So over 1/3 of our complaints in an outpatient setting are related to inefficiencies in this process and frustrations that then brings upon the patient. The rest of the integration work we've done, a lot of it is very clinical. So for example, we have a device that we use in our urgent care centers that's designed to, in minor traumatic head injury, determine two things quickly. One is there structural injury to the brain that would require a CAT scan to identify the lesion. And the second question it answers is, does this patient have a concussion? And if the answer to both those questions is no, despite the mechanism of injury, on occasion we can send those patients home without a needless referral to an emergency department and unnecessary radiation to the brain. So that's an ongoing project that is about to be rolled out platform-wide. We also have our EKGs sent via our electronic medical record in real time to local cardiology groups that Banner works with, and we can get real-time reads usually in less than 10 or 15 minutes, where we can properly disposition the patient to the proper level of care based on the cardiologist's recommendations. And the last thing we're doing is once we shoot an x-ray via our PACS system, the orthopedic surgeon on call for Banner Medical Group has instant access to that image. It can help us make a determination about expedited follow-up as an outpatient versus the ED versus routine follow-up versus no need for follow-up. So when you take all this work and sort of lay it out, I think it's fair to say that Banner Urgent Care Services is the most integrated urgent care platform in the health systems today. We're proud of the work that we're doing. It's a never-ending cycle to continuously try to meet the consumer demands in this day and age. And I'd like to turn it back over to Dana for the last slide here, which really is an impressive slide. And my IT and informatics colleagues have accomplished a massive amount of work in a short amount of time, and I think this slide kind of sums it up nicely.
Thank you. So again, as Rob mentioned, we're very proud of our work, and what we wanted to summarize and demonstrate on this slide is that not only were we able to build and implement this system, but this really shows that we are committed to ongoing improvement, that we didn't just implement and run and go off to other projects, that we went live and then we went back and then we revisited, we looked at data, we looked at where opportunities were, we've continued to grow, and this is ongoing maintenance that we want to continue the success of our urgent cares as well as make sure that we are taking care of Sophia. So we have all of this laid out, we have all of this data, we have all of this information, but what does that really mean? What does that mean to our patients and to our people? So I'm going to turn this over to Dr. Will Holland, who's going to walk through what this means.
Hi, my name is Will Holland. I'm Vice President for Care Management and Chief Medical Informatics Officer for Banner for the system. And you're probably wondering at this point why you see a girl doing a handstand in the water on the beach. This is actually my daughter, Madison. She was 9 at the time. This is about a year ago. And I'll tell you, I remember vividly that boardroom conversation that Rob, Dana, and I and others had about the power of integration versus having a best-of-breed system. And you know, I tend to be of the mindset that when you can integrate and share things in different venues of care, there's tremendous opportunities, and certainly they've shared some of the data behind it. But I thought I would tell you a little bit of what this actually means to a patient and their family. About a year ago, I was in Crotonville, New York, actually at a leadership conference, and there was some pretty amazing speakers there, folks from Harvard Business School, Wharton Business School, frankly talking to me about things that I don't usually get to hear as a physician leader. I was really enjoying it, and it was the last day I was there, was about ready to head to the airport, and my wife kept sending me a text, hey, you need to give me a call quick. And I would text her back and say, just give me a couple more minutes, I'll call you. We're almost at the tail end of this conference. And I forgot. I took the taxi cab back to White Plains Airport, which is a pretty small airport. It's got, I think, 3 jetways maybe, and I think the only food you can get there are some sandwiches. And so I'm sitting there, you know, holding a sandwich that I plan to eat on the plane. I'm on the jetway getting on the plane, and I get this phone call from my wife, who's not terribly happy with me for not calling back. And she told me that our oldest daughter, Madison, who was 9 at the time, the one in the picture, had hurt herself at gymnastics. She had fallen off the high bar. And for those of you that are not gymnastics families, and I'll tell you, we weren't a gymnastics family. My daughter just seemed to like it. It's a really confusing sport. It's hard to understand whether they're doing well or not. It's hard to understand the scoring system. So my wife and I, who are not terribly into gymnastics, just try to support our daughter through all this. But the one thing I've learned is that gymnasts are really tough. And so apparently Maddie had fallen a couple of days earlier, gymnastics. She'd actually done the rest of the workout and gone home and gone to school for a couple days. And my wife was really concerned. She's actually a family physician like I am, and she was really concerned because Maddie was holding her arm at her side and wouldn't move it. And I'll tell you, for those of you who don't see pediatric patients very often, that's a telltale sign that something serious is going on. Kids can't fake that. That's the way they try to hide that there's something more serious going on with their arm. And so I talked to my wife, and I said, let's FaceTime Maddie, and we'll talk to her about it, and we'll get her over to the urgent care and get her checked out. And my wife said, there's one problem. Maddie's locked herself in her room. And that was interesting to me for a couple of reasons, and I think for my wife also. One was we were just trying to think of how to get her out of the room, and the second one was neither one of us had any idea there was a lock on that door, so we didn't know where to find the key. So imagine me standing on the jetway, being that person in the jetway who's yelling into a phone via FaceTime while my wife is holding up the other side of her phone up to the door of my daughter's room, and I'm trying to very sweetly tell her to come out of the room, and I keep hearing a no. No. And eventually I have to tell her that if she doesn't come out when I get home, I'm going to have to put her on my shoulder and carry her out to my truck and take her to the urgent care to go get it checked out. And the reason that she was fighting this so hard is she had spent the entire summer training to move up from level 3 to level 4, which is a big jump for kids who are 9 years old. And her first meet was that weekend. And so she knew something was wrong. And she knew that it was likely going to lead to her not being able to compete in her meet, and she was pretty devastated. So I'm on the plane at that point, and I hear the announcement overhead that, hey, we got to close the door, you got to turn off your phones, all that. And I'm at least, excited by the fact that there's Wi-Fi on the plane, and I've got an Apple iPhone, as does my wife, and you can usually text back and forth via Wi-Fi on those. So I'm pretty excited about that part. I tell my wife I'll text her, and she has to let me know what happens, whether she got Maddie to the urgent care. And mind you, this is a Friday. I think I was going to land at like 5:30 or something on a Friday. So, I'm on the plane, and as fate would have it, the Wi-Fi didn't work. So I'm not able to text anything, and when the plane finally lands 5 hours later in Phoenix, I have this series of texts from my wife. There must have been 15 of them that were something along the lines of, I can't get Maddie out of her room. Okay, she came out of her room. We're in the car. She's back out of the car. And finally culminated with, they're at the urgent care, and I need to get over there right away. So I drove in my truck over to the urgent care, and I walked in, and I saw something I just haven't seen much. My wife was in tears. My daughter was in tears, and I'll tell you, my daughter's a really, she's a tough 10-year-old now. She was a really tough 9-year-old at the time. She's kind of my kid that's on autopilot. I hadn't seen her cry much. And my wife, we'd been married 11 years, and she's a physician and certainly had some, tough experiences growing up. I think only 2 or 3 times in our marriage have I seen her cry. So it was a pretty tough experience for me walking in, and they handed me an x-ray report that showed that my daughter had broken her arm. And like I suspect a lot of parents do, the first thing I said is, can I see the x-ray and see what happened? And the nurse practitioner that was in the urgent care pulled up the x-ray on our digital PAC system, and it looked about like this. And I don't know if you've seen a lot of x-rays, but sometimes the exposure can be off a little bit, and that's what you're seeing in this is an x-ray where the exposure is a little off. It happens sometimes in pediatric patients just because their body weight is a little different than an adult patient, and so it can make it a little challenging to interpret it. The nice thing about having a digital PAC system is that there's a density slider that you can do and a contrast slider that you can adjust it so that you can see it better. And so the nurse practitioner went to adjust it, and she was having some challenges adjusting and apologized that she couldn't get the view of it a little bit better. And it was funny, at that moment it occurred to me that I hadn't really identified myself as a physician. I certainly hadn't told her that I was the CMIO for the health system, or that frankly if she wasn't comfortable with using the adjustment knobs on the digital PAC system, it was probably my fault for not having the training get out there that needed to get out there. But I asked her if I could use the mouse, and she looked at me a little funny, but said okay. And I adjusted the density setting on it so that we could see the x-ray a little bit better. And if you see that arrow off to the right side there that's pointing at that bone fragment, it's not uncommon in kids to have a growth plate that's not fused in that area. But usually you'd expect to see that bone a little closer to the arm bone. She'd actually broken her medial epicondyle off. It's a pretty important bone in gymnasts, particularly those that are walking on their hands and doing those types of things. When that's in the right place and the ligaments attached to there, it gives you the stability in your elbow that you would need, very similar to a knee for moving around and pivoting. And if it's about 5 millimeters displaced and you're not a active gymnast, usually just conservative treatment and splinting can work really well for this. But when it's more than 5 millimeters displaced, oftentimes surgery is what's required. And in her case, it was about 2.5 centimeters displaced. So not millimeters, but centimeters displaced, pretty significantly displaced, and was going to require surgical intervention. And what happened next was really, I think, an interesting thing for us, for my wife and daughter and I. The nurse practitioner was able to talk to the pediatric orthopedic surgeon that was on call over at Banner Cardin's hospital, which is one of our pediatric hospitals. And they used the same digital PAC system that we use in the urgent care, and so he was able to pull the x-ray up and look at this. They're on the same EHR platform. He pulled up the note from the urgent care, was able to read the history of what happened. And then in terms that I can understand and my wife could understand and that my daughter could understand, explained to us what this meant, which is that it required surgical treatment. And I didn't know what to do next, and we asked, we need to bring her in to see you next week and get evaluated. And he said, well, as fate would have it, I'm on call at the hospital this weekend, and I don't have a lot on the OR schedule. Let's get her scheduled. And they already had all of our insurance information, everything else, again, being the same system, and we're able to get her scheduled the next day for surgery. And my daughter ended up having surgery. She's got a screw in her elbow now that looks like a number 8 deck screw from Home Depot, but is doing really well. She actually was able to get back to gymnastics about 4 months after the surgical repair for this, and is actually ready to make a jump from level 4 to level 6, which is kind of a big and exciting jump. It's exciting for us because we finally get to hear different music in her gymnastics routine. But super excited, and I really like this photo, which I'll end with, which is the two of us about 6 months after her injury. I'm actually holding the hand of the arm that she broke. So it's definitely functional moving, and I like this photo because she's 10 now and doesn't want to hold Daddy's hand anymore, but this is the last picture I have of her actually wanting to hold my hand. So I certainly hope that this story of, a patient story, certainly one that I didn't expect that I would have, gives you a really comprehensive view of the power of integration, not just from a a data and graph standpoint, which you certainly saw evidence of that, but gives you a feel for the power of an integrated experience in urgent care from the perspective of a patient. So with that, I'll end here, and hope you certainly enjoyed our journey through urgent care, and it's our hope that this can help you as you go through your journey. Thank you for your time.
Well, thank you, Dr. Holland, and the other speakers from Banner Health for joining us today and telling your Davies story. We want to remind folks where to go find more Davies use case webinars and information on how to apply for Davies Award. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. And we want to thank everyone for listening today, and have a good day. Thank you.